Welcome to KernTax's Conversations That Matter. I'm Michael Turnipseed, KernTax Executive Director. KernTax hopes you find this to be informational and beneficial to the time spent. Our guest today is Dr. Sharlet Briggs, Market CEO and President of Adventist Health. She's over Adventist Health Bakersfield, a 254-bed hospital, and Adventist Health Tehachapi, a 25-bed critical access hospital. She is a member of the Kern Leadership Academy faculty. Welcome, Sharlet.
Thank you. My pleasure.
So, how did a doctor in psychology and an author of several books find her way to manage hospitals in Bakersfield?
Well, I think I was always destined to be in hospitals. My brother was in the hospital a lot when he was a baby or a young kid. So we spent a lot of time in hospitals with him. I think as I really look at my journey, I started out in college as early childhood education and decided that wasn't for me. Moved on, graduated, and thought I could stay out of the work environment for a month. After all, I put a whole, years into college. I thought I could just rest. My mom said no. And so she ended up circling jobs in the newspaper for me to work in, and one of them was a skilled nursing facility. So I actually have worked at a skilled nursing facility. And then I decided I really needed to go find out my own job and got into medical records. And within 3 years, I was running the medical record department. And from then, I started turning our departments around. And so the hospital that was in the Napa Valley, hospital would give me different departments that they needed that were having problems. I was known for turning departments around. I then left there, went to a county hospital in Idaho, and worked there for 3 years, and then came back to the Napa Valley and once again ran that department. Ended up at our corporate office, starting some programs for them. And then they would send me out helping to turn some things in hospitals around. I retired for 4 years. And during that time, I ended up writing books, doing consulting in the efficiency side of healthcare. Actually got to work with Master P, the hip hop artist. So that was kind of a fun part of my life. Got my real estate license during that time. And then got called back into healthcare. And so once again, there was a hospital that needed to be turned around. And then they asked me to come down to Bakersfield. And the rest of the story is now I get to be the CEO, president of Bakersfield and Tehachapi, and I feel very blessed to be doing this.
Let's talk about the fate of rural hospitals, since Adventist really deals a lot with rural hospitals. Across California and the country, they are facing a lot of pressures, revenue pressures, complex patient populations with tremendous needs, and attracting and retaining providers. You want to talk about that a little bit?
Yeah, I think when you look at the rural health setting, it is especially now, it's extremely difficult. It was difficult before we got into this COVID situation or the pandemic. It is extremely difficult now, not only from a financial, but you think about rural health clinics or rural health settings that don't have a power of a big organization behind them, which Adventist Health does. In fact, we look at the rural community is really a niche for us, and it really fits our mission of living God's love by inspiring health, wholeness, and hope. So we have the most rural health clinics between the Rocky Mountain and here, and we have, as we look at hospitals, we're really looking at those hospitals in that niche. That being said, you're right. It is very hard at times to get physicians or providers to want to come into these settings. There's loan forgiveness for them, but it really has to be part of what they want to do, part of their mission. And where we're really successful is finding the person who wants to give back to a community like where they came from. And so as we really look at how do we step into this in a big way, we feel that's part of our responsibility.
Wow, that's pretty interesting. I know we were chatting one time and you said, what was your biggest challenge? And it wasn't necessarily getting them to come here, but like with the nurses, getting them to stay here.
Getting them to stay. So this has been my whole thing about how to get a nurse to stay. All right, you guys, we're our men, right? Where's our men so we can get them married and then we want them to stay, because I will say our biggest recruitment tool for Kern County is our low cost of housing. So if you're going to have a family, we have nurses who are moving from LA to here because of the cost of housing. So it is a recruitment tool, but once again, these nurses, these young nurses will come in for a period of time, get their experience and leave because they want to find a man. So I just need Kern County to step up on this part.
I was having a conversation with the city manager yesterday about recruiting. There's possibility of layoffs due to coronavirus of young police officers in many cities. And I said, and I think we have a lot of eligible nurses too, as a thing to go along with that play matchmaking here.
Yeah.
With these challenges, though, you've gone ahead and you've had a presence in the Valley before, but in the last few years you've expanded. You did Tehachapi, you bought Delano Regional Medical Center. Now you're managing Tulare. You're having quite a footprint in the Southern San Joaquin Valley, and you have a bunch of clinics you've opened, freestanding clinics. So how does that complement the whole picture of your care system? Now you're having clinics to feed the hospitals, and you're getting the patients from the sniffles to, and it followed here when I got a consolidation or a vertical consolidation of healthcare.
Yeah, it really is a downstream, right? So as you look at the clinics, I think as you look at the clinics, especially the clinics of where we have them in our rural settings, it isn't just about having a clinic. It really is owning that community. And I say owning that community because there's insecurities, or whether it's food insecurities or maybe some educational pieces. We have to go in and put our arms around that whole community. And that's why it's really critical to get the right provider in there that wants to do that. As we really look at the whole Adventist health approach, you think about it, not only do we have the Tulare, but we have Hanford, Tulare, Lodi, have Stockton. And so we're really looking at that 99 corridor. How do we make sure that we're bringing what we consider the best care? And when you look at Adventist Health, we're the only hospital in Bakersfield that has an A rating 6 times in a row. We've been top hospital, which is the only top 10% of the hospitals in the nation are considered to be top hospitals by Leapfrog, and we have that. So we feel we have a responsibility to bring that type of care into our other communities.
And these are really challenged communities. These aren't Tulare or but you're talking some smaller communities that maybe 10,000 people. It's the only healthcare that they really have.
It is the only healthcare they have. And so you really look at, not only is maybe the health challenged, but then making sure that you have that whole service around them. And
isn't there kind of a factor that the old small town doctors are retiring, and you're having to fill that void? For communities are having a hard time recruiting the old single practitioner that used to be there and did everything from tonsillitis to delivering babies, and now you have more sophisticated clinics there to provide better care.
You do. You have the more sophisticated clinics, and you're looking at maybe nurse practitioners or physician assistants in those. I think once again, as you're looking at that Marcus Welby practitioner is really what we're talking about, right? That dates us, if anything dates us.
MD.
Yeah, but you look at that isn't what we're seeing coming out of school now. I mean, we have the people that are coming out of school want their time off. So as you're coming out of school, they're wanting to have weekends off, or they're wanting to do an 8 to 5. And in your smaller communities, that isn't what happens. You are on all the time. You're there for your community. That's why I say you really have to find a person who has a mission for the community.
Well, let's talk about the $64,000 question, or maybe $1 million question, or $1 billion question, or $1 trillion question is coronavirus.
Yeah.
How has that affected Adventist Health and your operations, and what do you see going forward?
Well, if you want to talk first about a financial aspect, it's been a huge financial hit. You think about, we closed down our surgeries, which is really a feeder to the hospital as relates to revenue. In fact, it's our biggest feeder outside of the emergency room. So you close that down completely, only done urgent, emergent. So now what you end up having is that we've lost revenue. So cost of loss of business. In addition, there's a higher expense because of COVID. So there was a company called SHOP, SHOPP, and it's a pure procurement place, and they look at out there, and they're scanning the environment. And what they've said is our cost per day per bed before COVID was 32 cents. Our cost per day after COVID per bed is $28. So you can see my revenue's gone down at the same time my expenses gone up, and quite frankly, we're having to pay nurses stay bonuses because everybody's trying to get these nurses. So everybody's paying in addition stay bonuses. So our expense structure has significantly increased. So if our financial pressures is critical. There's a lot of I would say a lot of swirl out there that administrators want everything coded as COVID. That's not true. That's a nice swirl, but that's not true. Not only do I not make money off of COVID patients, so I lose money. You think about an ICU COVID patient is staying anywhere from 45 to 60 days or 60 plus days in the hospital. There's no way you can make money off of that, right? There's no insurance that pays you for that. So everybody pays by D, or Medicare pays by D or G. So you get a lump sum, and you may get a little bit more. And for those patients who don't get ICU care but are in the regular hospital, the same thing is true. You just don't make a good margin off of that patient. Those are considered medical patients where you just don't make margin off of those. So once again, I love to take care of COVID patients. I think it's our responsibility to take COVID patients, but just from a revenue expense structure, it's a really hard thing. We have received some CARES dollars from the government, which is nice, but doesn't begin to cover what the loss of revenue or the expense structure that we've had because of COVID. So we are looking and hoping and asking everybody to vote that we get more money to be able to handle this. And you look at those standalone hospitals. I mean, I look at those standalone hospitals who maybe didn't have a lot of dollars in their day. So, they maybe had $45 of cash on hand, 45 days. And you look at that and you look at how long this has gone on and the lack of revenue. And I just sit there and you look at the number of rural hospitals in California alone, or 6 hospitals that have closed. So there's a huge issue out there with sustainability, because it was tight before COVID, because Medicare keeps wanting to pay us less and less. Medi-Cal is paying less and less. And you think about Kern County, that's really a big population, Medicare and Medi-Cal. And so they're paying you less and less. And so while you could make it on that Medicare dollar, now you have your expenses up, and now even to replace any capital equipment becomes a big challenge. So it will be interesting to see how many places actually close in the future. I feel very fortunate that I belong to an organization that has underpinning support for that, but not every organization has that.
Changing times. So I assume then you had plans for expansion in the Northwest. That's probably on hold for now for a while.
Oh no, we're moving forward with that. That money's already been promised and squared away. So we are definitely still on track on building it. When you look at the number of beds that we need in Kern County, we still have a need to have more beds. And so we're on track to open that in 2024.
It takes a long time to plan things.
It does, but it's kind of fun. This is my second hospital that I've got to build. This one from scratch. Tehachapi was, we got to open that one and make some changes on that. So that was kind of fun. So this is really an exciting time for not only our hospital, our system, but for our employees to be involved in what really is important as they look at running a department, and obviously realizing the financial constraints of what you want to do, because it's like building your own house. You'd like to build the Taj Mahal, but what you can afford is whatever. So we're in that in the hospital side too.
And the cost for hospitals per square foot are many, many times what it costs to build a home. With
all the medical stuff.
All the medical stuff, that's for sure. One thing I found very interesting a few weeks ago, how when we were facing the whole reopening challenge, and you could only have like 6 cases a day or something, 90 cases, I think, for Kern County in 2 weeks, and some ridiculous number, and no deaths, and very few counties could make that work. And I think that the county got together with you, or you got together with the county, because Ryan also talked about this a lot, the doctors, the hospitals committee, and you had a meeting, you came up with a different plan to give the governor that then you had to sell the governor.
Yeah.
Tell us a little about how that all worked and how you came up with your plan, your data-driven plan, which was different than the governor's, and how you sold it to the governor.
Well, I think you have to get back to the original premise of why we locked down. And the reason why we locked down was because hospitals wouldn't be able to handle the cases that came in. And you see that in New York. And so what we take is that whole urban setting and we say, well, if it's happened there, it must happen someplace else. And so the presidents of all the hospitals from Ridgecrest to Delano, we're meeting every single week. Since it started, we've been meeting and just having discussions on and making sure that it's as we're looking at Kern County, how do we take care of Kern County, that we're having those discussions so that if somebody needs something, I mean, we've given supplies to different hospitals, almost every hospital we've given supplies to, they've given back some supplies so that we're taking care of each other because it's our community. And so when Mike and Zach reached out to us and said, you know, we'd like to have a conversation with physicians and the presidents on what would be a better indicator about if we should open Kern County. And it became very clear. You had to go back to the reason. Why did we close? And it was because of maybe the shortage of hospital beds and ventilators. We all hear it on the news. And so what we just said is if that's the reason why it's closed, and let's use that as the indicator, can we handle the surge within the hospitals in order to, if there was a spike, could we handle that? And, you know, Ryan and the team went up to and, you know, talked to the governor about it. He approved it. And we've been remaining steady. I think our public health department's done a really good job of making sure that we have the supplies we need, that they're opening up smartly with the things that need to happen and reviewing stuff. So I look forward, quite frankly, to being open. I think as a hospitals, we'll be able to handle it. And I think the answer should be, if you can't, then we call it, right? But to me, that's the adult thing to do. Have those discussions and really do it smartly. So as it was a good team of physicians and administrators.
But that was good, the community coming together and bringing the expertise and a different viewpoint, a different point of view in the process. So what's the post-corona, if there is a post-corona landscape for healthcare locally?
Oh, I think post-corona we'll have a different outlook on healthcare, right? So before, we didn't do a lot of virtual visits by physicians. It was out there. Some people had it. Now you're seeing, you know, we were seeing 75 to 80% of our care in our physician clinics being done virtually. That isn't for everybody. So I think what we're seeing is we're opening up clinics for those people who want to come in and should come in. There is a time when you need to see and touch. There's a time when we continue with the virtual. So I see you'll see that piece there. We're stepping in, Adventist Health, we're stepping into the hospital at home. And once again, that's technology driven. So if you come into the emergency room or you're in the hospital for a length of time and we feel like you really could be watched at home, we'll send you home into the whole hospital at home, which really means you have a doctor at your fingertips, you have a nurse at your fingertips, you have a nurse that actually just goes to your house also once or twice a day to check on you. But it's technology driven, and I think that's where we'll start seeing healthcare. Besides the brick and mortar, there will always be room for brick and mortar. But I think as we just really look at the technology piece of it, that's what will be really driven into the future.
So when they write books about this and how we handle this, how do you think, now we know coronavirus, but say there's something else down the road.
Yeah.
How do you, or maybe it's the coronavirus again next year, how are future pandemics going to be addressed differently? I don't think we can go through these massive shutdowns and do this on the economy and It's really scary.
Yeah, I hope we don't do that. I think, there's the quote that, says something about if we don't if we don't, learn from our future, we're idiots. Maybe that's not the right word, but you get it, right?
Yeah.
And I think that we have to be looking back and saying, based on what we know, based on now, hindsight, what could we have done different? What should we do different? Because I think that there will be something at some point in our lifetimes coming back, or after our lifetime coming down. And then did it make sense to shut down everything altogether? And I think it really becomes a question of is all equal, or is the geography different in different places? We look at Mendocino County. If they had any cases, I'm surprised, but they had very few cases, right? Modoc County had little cases. And when we really look at it, the majority of cases have come from skilled nursing facilities. So what have we learned in that we need to do different? And I think that that's my piece. I hope we look back and go, what did we learn, and how can we do it differently?
I think the staggering figure is the amount of people who are in nursing homes, and what happened in the nursing home industry, not just in California, where I think it's over 40%. Kern County, it's over 50%, but nationwide. Are nursing homes going to change dramatically? I mean, the State Department of Public Health, they inspect them and they certify them and do all those things. What do you think is going to be different? Because that is a critical part. When people leave the hospital, they need to go through convalescence, so they need other things. How's that going to change?
Yeah, I think from a hospital aspect, and I'll just answer that one first and I'll answer the other one. We're seeing less and less people go to skilled nursing facilities, because as we keep people less and less in the hospitals, the need for them to rehab in a facility is gone down. So for every day that you spend in a day, you lose a week or two of muscle strength. So we want you to be out of bed. And so we're really working hard on that piece there. That being said, skilled nursing facilities take care of our loved ones at the end of life. I had my aunt in one, and we trust people with our loved ones. And I think the devastating part of this one is that we saw where we had some issues with infection control. And so do I think that there will be changes in skilled nursing facilities as it relates to infection control? Absolutely. I think what we'll see is they have to have an infection control person. And I know my infection control person is part of my success. That's why we have less infections here than other people do, because they're always driving the care that needs to go around hand washing, the personal protective equipment that needs to go for a sick person. And I think that the devastating part to me is you hear stories about skilled nursing facilities saying, well, we still need our staff to come in whether they're sick or not because we don't have enough people. At that point, to me, you have a leadership problem. And there was a story, I can't remember, it was in an M state, you like that, Michigan, Maryland, one of those states,
Sure.
Right? Oh, one of the M states, I just remember that, where the staff, COVID started coming in, and about 15 of the staff said, we're not leaving, we're going to stay here, make sure that our people are safe. And they stayed for 61, 65 days and made sure their people were safe. Now that's dedication, right?
I think I was in Michigan. I saw that story.
Isn't that great?
5 days they hunkered down. I don't know where they slept. They obviously have kitchens and foods, but I mean, just to stay there and do that and understand the grasp of, we can't bring the environment in here. And to do that was quite those are people that are beyond the call of duty, leaving their families and their kids and their rest of their life. Just out there going into self-quarantine.
I think to me, that's a difference between accountability. We talk about people being accountable. That's ownership, right? There's a difference between accountability and ownership. That's ownership. That's my job to keep these people safe, right?
One hell of a culture.
Yeah.
That staff stayed.
Yeah.
And I guess culture really is everything. That'll be another conversation sometime about culture and organizations, because I know that's your expertise. As we get down toward the end, what do you think the 3 priorities are that we should be doing in Kern County to improve healthcare and healthcare outcomes to enhance our quality of life? Just three.
Just three. So I'll say the big one overall is that, so we are at the bottom of the index. I think everybody knows that.
Yes.
So our first step is to decide that we want to change that. I'm not sure that we've done that, that we say we want to change our health index. And there's multiple things that go into that. It isn't just food. It's all kinds of things that go into that. So I think as Kern County, we have to figure out if we want to change that. Once we decide that we want to change that, then I think we have the brain power to get people around the discussion. And if we all come together in that, I say Kern County is unstoppable. If they want something, we get it. I mean, we have the power to go get it, but we have to want it bad enough. And I think as I really look at what happened in this sense of COVID, and will that drive us to be a healthier community? Because we have a whole bunch of diabetic patients in Kern County, right? And so how do we go after diabetes in a way? In what are the elements of it? And I don't think it's one group can take it on. I think it really is Kern County coming together.
And maybe it's having another conference call or two with the 25 really smart people in healthcare and say, maybe we should start driving a discussion.
Yeah, and I think there's all kinds of people doing it, right?
They're all trying, but they seem to be fragmented. There's not this big force, like an invasion force, to say, we're going to tackle this on.
But I think you've got to have people outside of healthcare, because I think that we always feel smarter with people who are like us. And I think we need brains powers that are outside of that, asking questions that make us think of things in a different way, because we're just used to thinking in a certain way, right? So why don't they do this? Why don't they do that? And then you start learning the different elements of it.
You run the same little circles all the time. You need to do a little cross-pollinating. That's a good thing to think about. Well, Sharlet, I certainly want to thank you for your time today and your candid comments and insights. I think it was very educational for me, that's for sure. Thank you.
Thank you. Thanks for the opportunity.
To our audience, thank you for watching Conversations That Matter. We hope you found it beneficial today. And if you'd like to leave comments or ideas, please go to our website, KernTaxpayers.org, contact us, and leave your thoughts. Once again, thank you for watching, and thank you very much, Sharlet. Bye-bye.
Thank you. Bye.